Good evening, everybody. I'm Dr. Jennifer Wessels, and I am excited to introduce Dr. Kento Sonoda back with us again to discuss today a comprehensive guide to STD management. Tonight's presentation is delivered live, and our presenter is going to be available for questions following his talk. We know it's tempting to turn off our cameras during the virtual presentation, but we encourage you to leave your cameras on. It gives our presenter a feel for who's here with us at the talk tonight and helps us make sure we're not multitasking during this presentation. Feel free tonight to drop questions into the chat window, and these will be able to be pulled up after the presentation. I'll be monitoring the chat for questions, and I'll moderate them at the end when Dr. Sonoda is finished. You're also welcome to speak up and ask questions directly when the presentation is over. Tonight's presentation will be recorded. It will be uploaded to MAFP's YouTube channel for future reference. CME, though, is only available for tonight's live attendees. I ask also that you please complete the very short survey at the link that Bill sent in today's reminder email. And he'll likely also put that in the chat following the presentation tonight as well. The information entered there will be used to report your CME. And as a reminder, this is the second of 10 sessions that MAFP has planned to deliver our great, convenient, and interactive CME. If you find these sessions as convenient and informative as I do, I encourage you to nudge your colleagues into registering for future sessions. We have some great talks coming up, and I'll turn things over to you for tonight, Dr. Sonoda. Thank you.
All right, thank you so much. All right, let me share my screen. Okay. Can you see my slide? Does it look okay? All right, thank you so much. I always want to double check. All right, thank you so much for your introduction and some housekeeping stuff. So my name is Dr. Sonoda. I'm an assistant professor, Department of Family Medicine at the St. Louis University. And tonight I'm going to talk about STD, everyone's favorite topic, right? And the reason why I got interested in topic is that, as you see, AAHIVS after my MD, that means like American Academy of HIV Specialist. And so I got the HIV specialty training as a part of my residency program. And during the HIV training, as you can imagine, I saw tons of STDs and including complicated cases, which motivated to learn more about it. And I very much love to talk about this too. So that's why I chose this topic. All right. So first off, I want to kind of better understand the audience and how often you see the STD. So it'd be great if you can put in the chat box how often you see STDs in practice. If you're a student or not the clinicians, you can put on the chat like how often you shadow or how often you encounter. Oh, 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 okay. Can anyone read the comments for me?
It looks like quite a varied group, Dr. Sonoda. Some folks saying every day, some folks saying monthly, some a couple of times a week.
Okay, okay. First of all, thank you so much for your response. That helps me a lot. That I know, and it's great, great diverse group, and I hope you can learn something today. So first off, I want to show this nice infographic, and I got it from X/Twitter, and so it's a fun fact that the 1 in 2 sexually active young people will get an STD before the age of 25. That's a lot. And I was kind of get shocked and they created hashtag GYT, get yourself tested. And I think people don't talk about it, right? Like you don't talk to your friend, hey, I got the chlamydia or I got the gonorrhea, right? People don't talk about that. And so people don't know like their colleagues or friends got the STDs, but it's happening a lot. And I'll get to that bit more detail, but that would affect their life like later on even. And so it's important to treat them in a timely manner and a screening and also talk about and do the patient education at our clinic. And when we say STD, that is like a super like wide word and that includes so many conditions. And I feel like it's impossible to cover like all STD conditions just within an hour. So I chose three conditions to be able to like digest within 1 hour framework. And I kind of chose a topic and aspects based upon the clinical usefulness. So let's get started from the chlamydia. All right. So as you know, there are four types of chlamydia, and mainly I'm going to talk about the chlamydia trachomatis. And as you see, this is a nationwide data, but from 1985, the numbers been going up, and something happened 2019 or 2020, and it's called as a COVID-19 pandemic. And so the stat is kind of off because first of all, people don't go just for asymptomatic screening, right? Who want to go, right? And so that's why the number is kind of off. And also, people afraid of being interactive and socialized, and that's why the number kind of going down. But I anticipate the number will go back again. But this is a trend nationwide. And also, this is the data by sex and age. And not surprisingly, the most common age group is like 20-ish or 25 to 29. But I want you to pay close attention to older folks, like even like older than 65 years old or 55 to 64 years old. There are still some cases. And I think this is a really important point too, because it's easy to, think about and consider screening people for STDs around like young age groups, but for older folks, they still get too. So we are kind of biased, but I think as a part of routine questions, even for like older than 40 or 50 or 60, it's still important to talk about like sexual risk factors, and it's as a family medicine doctor, I think that's important to keep in mind. And some data by race and ethnicity. This is the national data. Black individuals have most cases, and then followed by American Indian, and so some differences by race and ethnicity too. And here's the Missouri data. And it's kind of plateaued lately, but it's hovering around 30,000 cases. And this is the data by age group, kind of following the national data trend, but the most common age group is 19 to 24. But still, again, as I mentioned on national data, you see some folks around 45 to 54 and 55 to 64. So it's important to keep in mind. And also, as you know, many patients are asymptomatic. So unless you screen, it, it, there's no way to know. And by race, it's kind of about the same. So black individual has the most common, most significant, and it's more common compared with white individuals. And looking at the local data, so as get darker, that means more common, more cases in this in the each county. So St. Louis City County and Jackson County has the most cases and rates. So the prevalence and incidence vary depending on where you practice. So if you have chance, I put the reference and resources at the end. So you might want to visit the website and check the how common the STDs are, because that may change how often you want to screen the patients. Next, I won't get into detail for this infographic and figure, but this is the quick review of chlamydia life cycle. What I want to say from this cycle is that, let's say you see the patient get exposed to chlamydia like 2 days ago or so. You test it, right? You may not be able to detect that because it takes time for chlamydia to grow in your body. So it is noted that the incubation period of STD chlamydia infection, it's around like 1 to 3 weeks. So it may take time. And so in your practice, you may want to think about like treating the patient empirically if if you indicate it, and if you strongly suspect the chlamydia infections. Okay. And next, it's kind of fun fact, but this is the rate of transmission per partner. So like that means how many, as they have more partner, the transmission rate would go up. And so it shows male to female transmission probability per partner is about 30%. And then female to male transmission probabilities per partnership it's kind of varies, but from 5 to 20%. And then I get to like some common symptoms, kind of bread and butter, but most common symptoms are cervicitis and urethritis for women. And it is not known that 80 to 90% of women are asymptomatic, and around half of men are asymptomatic for like urethritis. And then for PID, pelvic inflammatory disease, the common symptoms are chronic pain, infertility, and ectopic pregnancy. And there are some common other conditions too. But the important piece is, to me, like those are the three bolded symptoms, because that can affect their future life too. Yes, we can treat the chlamydia by antibiotics, but chronic pain can persist, and infertility uh, can significantly affect their life, and also ectopic pregnancy is a serious condition too. That's why it's important to treat in a timely manner and provide the patient education. All right. For men, it's kind of similar, but the common symptoms are urethritis, epididymitis, and also it is known that untreated rectal chlamydia infection actually increase the risk of HIV infection, and other symptoms are listed. And as a biomedicine doc, I wanted to touch on a little bit of pediatric conditions too. So for kiddos, now it's getting more uncommon, but it is known that the kids may get the conjunctivitis and pneumonia and trachoma, and that's why it's important to treat antibiotics prophylactically when they got born. But you may not see that often, but I just wanted to show some like important messages. All right. So some lab testing, and the standard is a nucleic acid amplification testing. And as I bolded, it's really important to test chlamydia based upon their sexual activities. So when you ask about the sexual activities, just not asking about, how many partners do they have or any protections or not. You may want to ask about what kind of sexual activity they do, especially in the case when they have some risk factors, having multiple partners or no protections, because they may just have isolated pharyngeal chlamydia infection. And also they may have the rectal infection too. So check that, and then based on their site, you would check the chlamydia. And if needed, you need to do the three sites of STD testing. I think this is a key point because we tend to forget about asking those questions. All right, and here's a kind of recap, but USPSTF recommends the chlamydia in all sexually active women 24 years or younger, and also in the women 25 years older who are at higher risk. And for men, it's still inconclusive, but of course, if you identify risk factors, I think it's pretty reasonable to screen those folks. Okay, and I'm getting to some treatment. So this is the recommendations from the CDC and IDSA. And for urethral, cervical, rectal, or pharyngeal infection, basically treatment is the same. The first choice is now like doxycycline, BID for a week. Used to be like azithromycin 1 gram single dose, but because of resistance, this is kind of new recommendations from the CDC and alternative option certainly still include azithromycin 1 gram single dose and levofloxacin. And a pregnant patient is still like azithromycin is the first choice. All right, now it's a quiz time. And so this is a 32-year-old cisgender woman presents to your clinic with abdominal vaginal discharge. She's diagnosed with cervical chlamydia, treated with course of doxycycline. She's not pregnant. Her two sex partners, both of whom are cisgender men and notified, and both received variation of treatment for chlamydia infection. She has been asymptomatic following the treatment course with a doxycycline. Which of the following should be recommended regarding routine follow-up chlamydia testing for this woman? 1, retest with NAAT 1 week after compression therapy. 2, retest with NAAT 4 weeks after compression therapy. 3 months after completing treatment. 4, retesting with NAAT is not recommended. It'd be great if you can put on the chat, and if you're not sure, let's give it a try, and that can help you remember what to do if you even couldn't get the right answer. Okay. Can anyone recheck the comments?
We've got a guest for 4 weeks and another for 3 months.
All right.
Another
Thank you
vote
so much.
for 4 weeks.
Okay, good. Thank you. All right. So answer is 3 months. So this is a recommendations, and I get to the more details. And this is called as a post-treatment follow-up. So routine test of care after treatment is not recommended, but retesting 3 months after treatment is recommended mainly for reinfection. Again, the chlamydia is really common, and it's very likely that the person keep having the same sexual patterns. So it's really common to have reinfection. So this is not necessarily testing to check the treatment failure. It's mainly just checking the reinfection for those individuals. So that's a key point. And also, it's not recommended to repeat the testing within the first 4 weeks after treatment because of false positive test results. So it's one of the key message, because sometimes I see a patient that came back like two weeks after treatment, and can you test it again? And and you need to say no because of false positive testing, and then you may feel like you need to keep treating the patient over and over again. So that's one of the key points. All right, that's a wrap up for chlamydia. And next time move on to gonorrhea, but I'm trying to engage with you all like maybe 10 minutes or so like this way, and I know it's kind of hard to engage in the Zoom format, especially in the recorded session, but I try to do my best. So for gonorrhea, let's get started. So epidemiology wise, there are like more than 700,000 cases in 2021, and it's going up, and they're more common in men for gonorrhea, and the highest rate is still the same with chlamydia 20 to 24 years old, and higher among the Black individuals, and it's more common in the South and the Midwest. And let me show the map. All right. So as you can see, the rate from the yellowish color is the like a low prevalence, and the lower rates of reported cases. And then as it get more like more blue, there are more cases. So as you see, we are here, right? So we have lots of cases of gonorrhea, and that's why it's important to suspect if needed. And this is another transmission rate. In gonorrhea, urethra to vagina per episode of vaginal intercourse is about 50 to 70%, and vagina to urethra per episode of insulative vaginal intercourse is about 20%. And so this is really transmissible and contagious. And there are some common symptoms. It's kind of same with chlamydia, but urethritis, proctitis, epididymitis, and those are pretty common ones. But the unique one is a disseminated gonococcal infection. You may have seen this. I've seen it in a few cases, and people develop with joint aches and skin rash, and it's important to keep this condition in mind, especially when you see inpatient settings. And female, it's kind of same with chlamydia again, but subsitis, proctitis, and also Bartholin gland infection, and PID, and hepatitis, and same with this disseminated gonococcal infection, conjunctivitis, and pharyngitis. And lab testing, again, same with chlamydia, it's important to test based upon their sexual activities. And if needed, please do the 3 sites testing. And same screening recommendations, grade B, especially for women, sexually active, or who have risk factors. And same with chlamydia for men. It's still inconclusive, but when you identify any risk factors for men, don't forget to screen them, even if they're asymptomatic. And there are some treatment recommendations here. So it's important to keep in mind that there are some difference based on the weight and also location of infection. For cervix, urethra, and rectum, treatment are follows. If someone is lighter than like 150 kilogram, ceftriaxone 250 to 500, and then if someone is heavier than 150 kilogram, 1 gram is recommended. And then for pharyngeal infection, dosage is different. So the reason is that the ceftriaxone is like kind of around the pharynx. It's hard to reach out, and that's why the dosage is higher than other infectious sites. So it's important to keep in mind. And that's why it's important to test all 3 sites too, because if you don't test the pharyngeal infection, you won't know the appropriate dosage. And here is a post-treatment follow-up. So is a routine test of cure at 7 to 14 days post-treatment. And the recommendation is kind of tricky, so I wanted to show. So cervix, urethra, rectum, not recommended. Uh, Again, because if you give ceftriaxone appropriate dosage, they be cured, and that's why it's not recommended. But for pharynx, again, it's so hard to reach out. Um, Treatment failure may happen, and that's why 7 to 14 days post-treatment routine test of cure is recommended when someone have pharyngeal infection. And then, and all of them are recommended to get tested 3 months after that. This is mainly because of reinfection risk factors. All right. And there are some uh, the suspected gonococcal treatment failure, and if someone meet the, even if someone when someone have appropriate treatment and no sexual contact and still symptomatic. In that case, when you suspect gonococcal treatment failure, the first you wanna start from retreatment. They could basically do the same uh, treatment that as you did the first time. Basically, again, like a reinfection is extremely common. So even if someone say, "Hey, I promise I didn't have any sexual activity," but like some may had or hesitate to talk about. So it's important to just try it again and see how it goes. And then if that didn't work, and then someone said I didn't have any sexual activity, then you want to try the alternative treatment, like a single dose PO, azithromycin 2 gram, not the 1 gram, and I am gentamicin 240 milligram. And then also you want to counsel the patient when to resume sexual activity. And here are some key points. So more than 7 days after treatment completion and asymptomatic, and also the partner also needs to be treated. And so partner notification, all sexual partner in the prior 60 days, and also it's important to do 3 months follow-up and talk about STD prevention, number of sexual partners, condom use, and PrEP. I'll get to the PrEP at the end a little bit. So as I touched on a little bit of importance of treating the partners. So now I'm get to EPT. Has anyone heard of EPT, which stands for Expedited Partner Therapy? If so, if it'd be great if you can chat on the comment like yes or no, and I promise I won't ask you to unmute yourself even if you type yes on the chat box. Hmm. Oh, sorry. The question is, have you heard of expedited partner therapy or not? Okay, good, good. Thank you. All right. So I don't think I hear this word often when I practice, so I thought that it's good to kind of go through a little bit. So basically, this is the treatment for partners in the situation when the partner cannot access the care for whatever reasons, and then like you provide alternative treatment for the patient, for their partners, and kind of close the loop. And those are recommended regimen for chlamydia and gonorrhea. And this approach is only approved for chlamydia and gonorrhea. It should not be used for other infections like syphilis infection or trichomonas infection or hepatitis C infection or HIV infection. This is only for chlamydia and gonorrhea infection. And is the EPT permissive in Missouri? And you may wonder, right? And it is. And now, like, this is the latest map updated in November last year. Most states are permissive. And if you compare the map now, like 13 years ago, so there are way more states who prohibited that practice, but now they're getting more and more permissive for EPT. And each each state has a different rules around that, but basically in the Missouri, especially if that partner is under your practice, uh, you can write the script under the partner's name, or you yeah, so basically the most common practice is that you see the patient in front of you who recently diagnosed with chlamydia or gonorrhea infection, right? And then you write the prescription under in the chart of the patient, and then put the comment for the say like partner treatment or EPT, and then it should be get processed, and it's approved by the Missouri. And you can visit more details on the state website and under CDC. And I put the link on the reference list. All right, now I'm get to syphilis infection, and then I will secure enough time for the questions at the end. So syphilis infection. So as you know, syphilis is been increasing nationwide, and it couldn't list the 2022 and 2023, but it's been increasing on the nationwide, and they are more common in men, and the most common one partner is 38% MSM, a men who have sex with men, and most common in 25 to 29 years old of age, and most common among Black individuals, and common in West and Nevada and Mississippi. And but we, Missouri still has kind of high rate. It's not the highest, but syphilis has been pretty getting worse in Missouri State. So it's important to keep in mind. And as you see, it's been increasing, and I just wanted to go through some basics for syphilis infection. So this is a primary syphilis infection, and this happens 2 to 3 weeks after the acquisition of uh, s- infection. And then the more common sites are penis and labia and the anal region and mouth, and really contagious in this phase. And it can heal on its own 3 to 8 weeks. And especially this is not the pain, like a not the painful at all. Patient may not notice it or just let it go and heal on its own, but it's really contagious. And then secondary infection, secondary syphilis, this happens around 4 to 10 weeks after the acquisition. And the common symptoms are generalized body rash, mucus patches, uh, condyloma rara, and alopecia. Those are common symptoms. And I listed a couple typical pictures. It's kind of textbook. All right. So you might heard of this before, but I just wanted to show some uh, algorithm. And one is called as traditional, and the other one is called as reverse testing algorithm. And this is a traditional testing algorithm. So basically you start from RPR, and this is non-triple testing. We start Traditionally, we started it mainly because RPR is more sensitive and less specific. And then for DBPA or other triple normal testing is less sensitive but more specific. And that's why this we use this order. But nowadays, the the and also the confirmatory testing was more expensive in the past. But because of advance in medicine and also the price for confirmatory troponemal testing is getting more affordable. And that's why some institutions started to use this reverse testing model. And so, I mean, there's nothing to go right or wrong. But when you see someone use the reverse testing algorithm, that's a rationale behind it. And there are like 30 or 40 pages of uh, summary documentation from CDC last year. So I added the reference into my resource section. So if you want to learn more about that, you can deep dive into it. And this is a screening testing, and there's no routine screening testing isn't recommended for men who have sex with women or women who are not pregnant. But there are three populations are recommended to have routine screening for syphilis infection. So it'd be great if you can type what kind of populations we should screen for syphilis infection. Okay, now I can see the chat. So I see MSM, pregnant woman. Okay, good, good. Thank you so much for your participation. Yes, those are correct. And one more, and that is HIV patient, and or patient with HIV infection. And they're routinely recommended at least like once a year, and also first visit. Oh, great. Oh, thank you so much. Sorry, I just catch that. So thank you. Yeah. So those are three populations are routinely recommended. Yes, you can do them more often, but at least once a year, those populations should be screened for syphilis infection. All right. Here are some lists of treatment. Yes, penicillin is the first choice for primary, secondary. And if someone have penicillin allergy, you can use doxy, zithromycin, ceftriaxone as a alternative. But like as you know, like you hear, I'm allergic to penicillin. Mom told me you should not take penicillin, and you hear that all the time, right? And there's a great article from JAMA about the penicillin allergy and how common it is, but at the same time, how common is that like they're actually not have a real penicillin allergies because when they are kiddos, when they have virus infections, fevers and runny nose, and also they have skin rash from virus infection, not necessarily from penicillin antibiotics. And then, mother or parent, caregivers suspect the penicillin allergies, but actually it's not coming from penicillin. And so it's important to get to like know more details about the allergy history because you want to choose what works for the patient. And also, it's hard to pronounce, but there's a reaction after the penicillin treatment when you using antibiotics for syphilis infection, right? So people can get sick. So it's not a side effect from the antibiotics. So you want to provide education ahead of time to the patient, and so that especially for penicillin injection, it doesn't matter because it's basically a single shot. But for other antibiotics, doxy and ceftriaxone, um, you want to provide that education for the patient. And then for the post-treatment follow-up, it's important to observe there are at least fourfold decrease in non-troponemal titers, and their routine multiple follow-up are recommended, and the frequency and interval are slightly different, whether they have HIV or not, and that's what I listed on the slide. So you can reference that in case if you see when you see the patient with HIV infection. Okay, and this is a latent syphilis infection, and when they got the early latent syphilis infection, uh, the treatment is penicillin 2.4 million a single injection. But when they got the latent syphilis infection, the treatment is different because they need to get 3 shots once a week. And so it's important to keep in mind, and also important to ask the questions and the point to get infected. And lastly, it kind of the same with other uh, infections, but important to stay away from sexual activity more than a week after treatment. No symptoms on mucosa on the skin, and partner should be treated. And yes, it's really important to talk about STI infection prevention. And as I listed the prep at the end, I wanted to touch briefly on prep, as this is part of my uh, area of expertise. So very briefly, so those are common indications and recommended by CDC. So recent STI with syphilis, gonorrhea, or chlamydia infection within 6 months. Actually, CDC excluded chlamydia in young women because the chlamydia is really common in those populations, but the other organizations still include the chlamydia infection. And other indications include inconsistent condom use, drug use, and partner with HIV infection. And there are mainly 2 types of PrEP. And one is a pill form, and it comes from Truvada or Descovy. And Truvada has been in the market more than 10 years, and now generic medication is available. And also, there's so many like state or local resources, and so the patient should be able to access that. And also, it's kind of relatively new. It came out around 2 to 3 years ago. Now injection type, and the patient get it every 2 months or so at the clinic. And then I don't want to get too much detail, but I wanted to quickly mention how important it is to talk about and provide a prep treatment when you see the patient who have the indication that I listed. So now those are references, and those are fantastic resources I wanted to show a little bit. So there's a national STD curriculum developed by University of Washington. They have the great resources around this area. They have STD curriculum. Also now they also have HIV curriculum. Also, PrEP curriculum just came out. So if you want to learn about that, this is a great resource to learn. And also, if you need any like advice from experts, UCSF has clinician to clinician advice and for free. And especially in the area of HIV, Hep C, STD, PrEP. You can get the real advice from experts. And also some great articles listed from the AFP, from sexual history, and also great summary by AFP about the STI. And I want to thank you to here, Reno, WashU associate professor, and also she's a medical consultant for CDC, STD prevention. And I double check with the content with her, so I want to acknowledge her contribution. And here is my contact information. So thank you so much for your attention. And now I love to take any questions. Thank you.
I had one question, and this is a minor thing, but when you first covered chlamydia, we had this dip in 2020, and it was sort of like you implied that was probably COVID related, but the other two didn't seem to dip nearly as much or at all. So, since the risk factors are kind of the same thing, I wondered if you had any other thoughts on that.
Yeah, that is a great comment. So basically, like CDC made a comment about that too, because their main point is that they don't think they're able to capture the accurate numbers of chlamydia, gonorrhea, syphilis infection, because first of all, they do not seek out the care, right? And also, I think what happened is that the chlamydia typically do not manifest any symptoms, but gonorrhea does a bit more than chlamydia. So patient might have seeked out a bit more than other STDs. That's my hypothesis, but I think nobody knows what happens. And the main bottom line is that yes, they showed some number, but they don't think that's accurate number. But thank you so much for your comment. I see some. Any other comments, questions? I'm happy to take any minor comments or anything too.
Well, thank you very much, Dr. Sonoda. It looks like that's all we have for today. So you explained everything so well. We don't have any more questions. So thank you all. And thank you for your presentation. Thank you for your attention today. And please check out the survey from Bill that is also dropped in the chat tonight. The survey will count as your CME reporting, so please make sure you click that link, and that will get taken care of for your credit for this evening. All right, thank you very much, everybody.
Thank you all.
Have a good night. We'll see you next month.
Bye-bye.